Hello everyone, and thank you for being here on the last day of the Congress. Indeed, this topic has been discussed in another hall, so I hope it will not be overlapping all the discussions, and I tried to eliminate some of the information which is already mentioned. We will be talking about ADHD definition, and if there's a resistance in ADHD, there are comorbidities, because pure ADHD is responding 80% to oral medication, and when we add antipsychotics, there is a promising fruitful treatment. However, when there are comorbidities, it is complicated. We don't have any difficulties in diagnosing it in primary school, adolescence, and adulthood. We have different staging and diagnostic tools for that, but when it is in school period and when the functionality decreases, it could be even a thick or anxiety disorder, but we need to search for ADHD. This is something that is curable, and for the functionality, we see some benefits, and 60% of it could improve, and some rest untreated. For ADHD childhood, there is no findings that there will be 100% treatment improvement for the condition of that patient. And there are follow-up studies published, 50% total recovery, and for 50% persistent for ADHD. And it doesn't have to be the same. There could be some differences, of course, but aims of ADHD treatment, some patients parents don't want to have treatment. You need to explain all of it, and they say you are talking about some maturation problems, so we don't want to have the treatment. However, while treating the patient, the aim of us is there is no disease, but there is patient. This is our psychiatric approach. We need to think about the school, parents, mother, father, and social economical situation, and some other access to healthcare professionals other than physicians. We need to think all about this. And for the ADHD treatment, as I've stated, we try to reduce symptoms, individually tailor it, and improve educational outcomes, and reduce family and school-based problems. There could be a couple of years lost, and some early age marriages or early age involvement in criminal acts could be on the table if we do not treat those patients. So what works? In terms of evidence-based treatments, best evidence for stimulant medications. There are randomized control studies a lot, so that's why we do have evidences more in that area. And then after behavior treatments and psychoeducation for parents and school, if you do remember the evidence list classification, for mild to moderate cases, behavioral treatments also effective, but psychoeducational treatment is an inseparable part of our treatment pattern. Psychosocial interventions are quite important. Why? Behavioral therapy, the individual, and it is not always generalized. It is not always increasing the dosage, but as a clinician, we need to think about the patient, the child. Psychosocial interventions should be also added in accordance with the age group and family status. You need to think about that. In early days of this Congress, there could be some school-based studies. This could be one point lacking in our country right now. and in every school, consult teachers or school psychologists should be available. And psychosocial interventions are in the primary base. And for non-pharmacological interventions, all guidelines apply psychosocial interventions. And the main pharmacological target in ADHD is imbalance between dopaminergic and noradrenergic systems. We know that this exists and we try to balance that situation. And then alpha-2A receptors and D1,4-DA, we try to balance those, improve the situation. Decrease the sound and noise for DA, and for NA, increase the connectivity and signals. And the target of medication to increase the signal power to an optimal level. Then again, optimal dopaminergic and noradrenergic balancing is quite important. DA and NA, we need to create a balance in two arms. The initiation steps for the intervention, as it is in all psychiatric diseases, we need to be sure about our diagnosis, use category criteria, and of course it is not just scale-based or criteria-based physicians, but we need to also think about showing that scale will help the parents to be involved in the treatment, to give consent for the treatment. And psychiatry is somehow subjective, and vague evaluations are quite common in psychiatry area in terms of public. And assess the developmental level of the child. The physical examination should be performed. If the child could get tablets, for example, you need to evaluate that. If they can't swallow it, there is no meaning for prescribing medicines. And physical examination, as I've stated, if it is required, there should be referral, and the methamphetamines or amphetamines. For those stimulants, there are some studies for the efficacy and safety of them, and in Turkey only methylphenidates are used. We do not have amphetamine. Other stimulants, short-acting, long-acting ones, and also since the age 3 we may start methamphetamine. How to use those stimulants? We all do know the details, so I don't want to go into details, but if you want, I can share the presentation. There are non-stimulant medications, and atomoxetine is the most commonly used one worldwide. In US, they have long-acting forms to use. Imipramine is a norepinephrine. Imipramine is available in our market. In the first is of my studies, there were the other non-stimulant medications. However, we don't have tofrenin use, for example. There were some syrups used as antipsychotics. Maybe 10 years later, imipramine could be also out of date. I don't know what will we see in the future. And alpha-agonist, of course, guanfacine, clonidine, extended release version of them are used, and bupropion as antidepressant. NICE guidelines states that it is not stated as highly effective in the use of child patients. imipropin 2 to 3 times a day, clonidine while using that. For ADHD, it could be an option. We can ask for it in our country. Pharmacists could help you to get the medication, and the dosage should be tailor-made again. For interventions without much evidence, what are those? Those are valid for abroad as well. Acupuncture, meditation, homeopathy, hajamat in Turkish practice, for example. There are no evidence-based studies, of course, for that, but this could be somehow alternative. In preschool ages, the parent training is important, and then the treatment models could be initiated. Mild to moderate, there could be a waiting process, but for severe patients, atoxanopin and dexamphetamine combination could be used. And for the effective dosage, if the child could tolerate the dosage, you may try the maximum dosage efficient and available. If you do think there is a severe pain, then they can use combination treatment. And again, for severe cases, you may alter the medication. There are some antidepressants. What about resistance? What should we do understand from resistance? Which cases are resistant? And can we say any untreated case is resistant to treatment? If still no response after 6 months, consult with a specialist, of course, and we can say there is a resistance, or there is a behavioral approach, but there are nothing improved. Then we can say again it could be resistant, and some lack of social social facilities, opportunities, a very poor neighborhood, poor parents, and some other problems. It could cause some problems in the course of the disease as well. And for classical traditional patient profile, those are the must not a must. You may individualize all of them in accordance with your patient profile. If we start with a methylphenidate, then atomoxetine could be an option. We can check the side effects, and psychosocial interventions and combinations could be added. Clonidine, TCAs, methylphenidate. And if there is still resistance to the treatment, then I will be talking about in detail for the other options in NICE guidelines. Center of Excellence in the UK, AK is for America, United States, and DGK-JP is the German guideline. Both atomoxetine and stimulants are in the primary case. Methylphenidate, in general, for Canada, for example, they put it in psychostimulants as the first preference. Propion, morphine, citric antidepressants, etc. are in the third line. And there are some guideline names. Regarding the patients, you may see there could be a judicial process. We have to be sure that we are following guidelines in a legal process. In our country, I think it was just published on latest 2013. It is updated in 2013. As far as I remember, stimulants and are in the first line treatment, and again in NICE. While initiating stimulant treatment, you may start with long-acting methylphenidate, and for other social interventions, it will be getting better in the later stages. And FDA approved once clomidine and guanfacine are FDA approved, and then again we hope that those will be available in Turkish market as well. But during the day, it could be 2 to 3 times a day as a dosage. So when you will start it, you may check those. Atomoxetine could be listed as first line, but methylphenidate it is less effective when compared with the methylphenidate and alpha-2 agonists. It is for ADHD plus conduct or ADHD plus tic disorders. This could be an option, and for me, methylphenidate and antipsychotic, but there are still problems in behaviors, and if those are uncontrolled, methylphenidate, antipsychotic plus clonidine. I do add clonidine to some combination treatments. It is to augment the results. And we see some benefits from that use. This thick, or when it is aggravated with thick, for example, there could be good results to obtain through this treatment. And clonidine, there is the weight limitation for dosage adjustments, and the effect of those could starts in a later stage to keep in mind. And TCAs, imipropin, for example, and venlafaxine, it is first released as an antidepressant. However, for adolescents, when they have this attention disorders and stress because of the exams, etc., it could be used. It is not dopamine based, but we can adjust our treatment accordingly. And the off days, for the resistance to treatment, they are talking about those off days. It is stated that it could be individualized, especially for tolerance. A constant use of antidepressants. Instead of that, there could be these off days. We may change the situation now, but how? For example, if the child has problems at school using the medication during the school days, but taking off days when there is no school, no, it is not the case. But if there are some symptom improvements in the child, then you may just have those off days. But for example, physician could offer off days, but parents say, oh, when we had this off day, the child was crying all the time, and we just borrowed a couple of pills from our friends. This could be the situation also, so this should be monitored. And for ACAP guidelines, it is recommended to have off days. And for classical ADHD, there are no treatments, but if the symptoms are still ongoing for 9 months, and if there are some negative situations, then medication could be initiated. And for the comorbidity treatment, as you do know, there could be destructive behavioral acts, anxiety, depression, behavioral disorders, etc. Those are very common, and there are guidelines from Texas Medication Algorithm Project. This is a very short explanation of it. Indeed, the comorbidity treatment is adjusted here. What can we do? First line, methylphenidate is administered, then amoxicillin, no effect. Bupropion, antidepressants are given, but in the meantime, you have to re-evaluate the patient, and you may get consultations. Omnipotent, I am the expert in this area, I'm the specialist, I have my doctorate degrees. No, it is not the case. In every stage, another opinion could contribute to the diagnosis, so we need to have consultation. You shouldn't be ashamed of yourself to ask for consultation. And those comorbid situations, if there's severe aggression, for example, I10 stated valproic acid unresponsive situations. It is listed here as a stimulant, but antipsychotics, psychomatics are listed before that acid indeed. Behavioral interventions are also in the list, and at the end there is another consultation. But for example, there's anxiety disorder, and atomoxetine could be administered directly. But you need to check the anxiety first. If there are no response, then you may skip to stage 2. Methylphenidate or amphetamine could be used, and for chicks also it is available. The ones who wonder the details could check the Texas guidelines there. Cognitive training reduces total ADHD symptoms and inattention, but have no effect on hyperactivity and impulsivity. Sometimes parents say, I put them in attentioners, play attention as applied, I didn't use this games, medication, etc. But we need to inform the parents as well in the meantime. I will skip those. For remission or endpoint scores, we may check those as well. What are the scores in the first stage? And what are the improvements? It could be syndromatic or symptomatic. There are some symptoms, but it doesn't have met all the diagnostic criteria. It could be functional. We need to classify all of them by using the scales. Again, there are partial responders. For those partial responders, we need to minimize intolerable side effects, and for children with multiple comorbidities having significant academic, social, and occupational impairment, those could be the ones listed in this group. And in all algorithms, you need to reconfirm your diagnosis. It could be something different. Non-pharmacologic and pharmacological treatments should be known very well, and alpha agonist combination could be an option. Disruptive mood dysregulation, DMDD, is very hot topic, and the symptoms could be treated with ADHD treatment phase. I will just conclude. Antipsychotics, there are some publications for that, and for combination treatments, aripiprazole combination treatment for depressive and anxiety symptoms with ADHD, with methylphenidate combination, there are some promising results. But we need to start with low dosages at first. It's the end. Thank you.